Welcome to the Deep Dive, where we aim to give you that critical shortcut to being truly well informed on complex medical topics. Today, we're setting our sights on one of the most remarkable and, well, let's be honest, at times most troublesome joints in the human body, the glenohumeral joint. It's an absolute marvel of mobility, isn't it? Allowing an incredible range of motion. But that very freedom, as we'll explore, it comes at a significant cost, a predisposition to a wide variety of injuries and challenging conditions. Our mission today is to truly unpack how the body pulls off this incredible biomechanical feat and what happens when that delicate balance is upset. To guide us through this fascinating subject, we are joined by an esteemed expert in orthopedic surgery. It's a pleasure to have you with us for this deep dive. Could you start by giving us an overarching perspective on why understanding the glenohumeral joint, often simply called the shoulder joint, is so critical for us as medical professionals?
Thank you. It's a genuine pleasure to be here. Indeed, the glenohumeral joint is absolutely central to upper limb function. It literally facilitates, well, virtually every interaction we have with our environment, from the simplest gesture, to the most complex athletic movements. Its unique ball and socket structure makes it the most mobile joint in the human body, a truly diarthrodial multi-axial joint, meaning it's designed for free movement across multiple planes. But what's truly fascinating here, and indeed the fundamental paradox of this joint, is that this very design, while granting incredible freedom of movement, is also its Achilles heel.
Right, the mobility versus stability trade-off.
Precisely. From a clinical standpoint, this inherent design compromise means it's profoundly prone to a wide array of pathologies. Things like recurrent dislocations, debilitating rotator cuff tears, degenerative conditions like osteoarthritis, just to name a few. We as clinicians see these conditions, well, daily. So managing them requires a profound understanding of not just what the anatomical structures are, but how they interact dynamically, and critically, why they behave as they do under physiological stress or due to pathological degeneration. It's a continuous, complex challenge for practitioners. We are constantly aiming to strike that perfect balance, between restoring stability to prevent further injury and preserving optimal function so our patients can return to their daily lives or even elite sport. This delicate balancing act truly underscores the critical importance of nuanced, in-depth understanding of this joint.
That truly sets the stage perfectly, highlighting that incredible balance. Let's begin our deep dive then into the foundational anatomy. When we talk about the glenohumeral joint, what are the primary articulating surfaces and the core components that make up this unique ball and socket system?
Right. At its core, the glenohumeral joint is formed by the articulation of the humeral head, which is essentially the ball with the scapula's glenoid cavity, the socket. Both of these articulating surfaces are covered by articular cartilage. This is a remarkably smooth, low-friction tissue, absolutely crucial for enabling smooth, effortless movement and dramatically reducing friction between the bones during motion. Interestingly, this cartilage is thickest at the axial center of the humeral head and thins peripherally, while the glenoid cartilage exhibits the opposite pattern, being thicker at its periphery and thinner centrally. This subtle variation actually contributes to load distribution.
Okay, so even the cartilage thickness is specialized.
Exactly. Now, a key anatomical feature that directly dictates its high mobility, and conversely, its inherent instability, is the highly disproportionate size ratio. The humeral head is considerably larger than the shallow glenoid cavity. It's often cited as having a roughly 4.1 surface area ratio.
4-to-1, that's quite a difference.
It really is. This mechanical incongruity is what allows for such vast emotion, but it simultaneously contributes directly to its inherent instability and predisposition to dislocation. It's quite striking to consider that despite its size, only about 25% of the humeral head surface actually makes contact with the glenoid cavity at any given time during movement. It's a testament to evolutionary design maximum mobility, but yes, at a price.
So the bony socket is quite shallow then?
Very shallow, yes. However, its effective depth is significantly enhanced by the glenoid labrum. This is a fibrocartilaginous rim that spans its periphery and its triangular in cross-section. The labrum effectively increases the socket depth in the overall surface area, thereby enhancing passive stability. Clinically, it's important to remember that the labrum is continuous with the tendon of the long head of the biceps brachii, or LHBT, at its superior aspect, and it also serves as a critical insertion point for the anterior band of the inferior glenohumeral ligament.
Okay, so the labrum deepens the socket, making it a bit more like a cup. But it sounds like the joint still requires significant soft tissue support beyond just the bone and the labrum. Could you elaborate on the joint capsule and that intricate network of ligaments reinforcing it? Are these just static ropes, or do they contribute in a more dynamic way?
That's a crucial observation. While the labrum adds depth, the joint's true passive strength comes from an elaborate web of soft tissues. Encircling these articulating elements, the humeral head and glenoid, is the glenohumeral joint capsule. It's a fibrous sheath that forms a continuous support structure, extending from the anatomical neck of the humerus to the glenoid fossa rim. And it's notably loose and redundant, which, as we discuss, is precisely what allows for the extensive range of motion the shoulder enjoys. This extensibility is key to its mobility, but also its vulnerability.
Right, that looseness allows the movement.
Exactly. Now, within this loose capsule, we find distinct thickened bands known as the glenohumeral ligaments. Specifically, the superior, middle, and inferior glenohumeral ligaments. These were first meticulously described way back in 1829. What's truly fascinating here is that, as you alluded to, they are indeed more than just static ropes. Unlike many traditional ligaments that primarily carry a pure tensile force along their length, these glenohumeral ligaments become taut at varying degrees of abduction and humeral rotation.
Ah, so they tighten up depending on arm position.
Precisely. They are intrinsic to the glenohumeral region, reinforcing the capsule and serving as primary static stabilizers, crucially preventing anterior shoulder dislocation. They act as dynamic tethers, you could say, each with a specific role depending on where the arm is. Let's break them down, because their individual roles are critical for clinicians. First, the superior glenohumeral ligament, SGHL. It's the least variable of the three and becomes taut in adduction. It effectively resists inferior translation of the humeral head when the arm is by the side. It also plays a vital role in the biceps pulley system. A component of the SGHL is also known as the coracoglenoid ligament, which contributes to anterosuperior stabilization.
Okay, the STHL mainly for when the arm's down.
Correct. Then there's the middle glenohumeral ligament, MGHL. This one is the most variable in its anatomical presentation. Its primary function is to prevent anterior-posterior translation in the mid-range of abduction, typically around 45 degrees of external rotation. Its variability means that its absence or, atypical morphology can sometimes contribute to shoulder laxity in this range. We often see it described as cord-like in about 86% of people.
So the MGHL is key in that mid-range movement.
Yes. And then we have the inferior glenohumeral ligament, IGHL complex. This is clinically paramount. It's by far the most commonly injured of these ligaments, particularly in traumatic instability. It's actually a complex with three distinct regions: a superior band, an anterior axillary pouch, and a posterior axillary pouch. The anterior band, anchoring securely to the anterior labrum, is the primary static restraint to anterior and inferior translation when the arm is at 90 degrees of abduction and maximum external rotation. Think of that highly vulnerable late cocking phase in overhead throwing.
Right, the position where dislocations often happen.
Exactly. This anatomical reality makes it a critical weak link in traumatic anterior instability. Its detachment from the labrum is precisely what we identify as a Bankart lesion. Conversely, the posterior band of the IGHL is the most important restraint to posterior subluxation at 90 degrees of flexion and internal rotation. And its tightness can actually lead to what's known as internal impingement.
So the IGHL has both anterior and posterior roles depending on rotation.
Absolutely. Beyond these intrinsic capsular ligaments, other crucial ligaments contribute to overall shoulder girdle stability. There's the coracohumeral ligament. It's a dense fibrous structure supporting the superior aspect of the capsule. It extends from the coracoid process to the humeral tuberosities and notably envelops the long head of the biceps tendon. It limits posterior and inferior translation and also external rotation and adduction. Then the transverse humeral ligament. It's often described as securing the LHBT in the bicipital groove. But interestingly, more recent research suggests it might not be a distinct ligament itself. It might actually be formed by fibers from the subscapularis and supraspinatus tendons. And the coracohumeral ligament, it basically forms the roof over the biceps tendon.
So its status as a separate ligament is maybe debatable?
Somewhat, yes. The coracoacromial ligament is next a robust triangular band. It's extrinsic to the joint itself, but forms a crucial part of the coracoacromial arch, that osteoligamentous roof over the humeral head and rotator cuff. Abnormalities or compression here can unfortunately lead to subacromial impingement syndrome.
The impingement space.
Precisely. And finally, we also have the coracoclavicular ligament, the conoid and trapezoid, and the acromioclavicular ligament. While these mainly stabilize the AT joint, their proximity means injuries there often coexist with glenohumeral damage. A comprehensive assessment is key.
Makes sense.
Lastly, to ensure smooth mechanics, we must mention the synovial membrane, lining the capsule and secreting synovial fluid to minimize friction. And there are multiple synovial bursae, like the subchromial, subcoracoid, and subscapular bursae. These act as essential cushions, reducing friction between tendons and bone. The subacromial and subscapular bursae are particularly clinically significant due to their vulnerability to injury and inflammation.
That's a truly comprehensive look at all the structural components. It really feels like the body has gone to extraordinary lengths to allow movement but maintain some control. You mentioned earlier the interplay of static and dynamic stabilizers. We've covered the static ones now. Let's really unpack this. How do these two categories work together in concert to maintain the shoulder's remarkable yet clearly precarious stability?
It's a critical distinction, yes. And understanding their interplay is absolutely fundamental to appreciating glenohumeral stability. Static stabilizers, as we've just discussed, are the passive restraints. They provide inherent stability primarily through their fixed anatomical configuration and mechanical properties. These include the osseous articular anatomy itself, the congruity, or rather the deliberate incongruity, between the humeral head and the shallow glenoid.
That 4.1 ratio again.
Exactly. And the concavity of the glenoid is, of course, deepened by the glenoid labrum, which increases the socket's depth and serves as a passive stabilizer. Also in this static category are the glenohumeral ligaments, the joint capsule itself, and even the negative interarticular pressure within the joint.
Negative pressure, like a suction cup.
Pretty much, yes. It creates a subtle suction cup effect, helping to keep the humeral head centered. If you perforate the capsule, releasing that pressure, the humeral head can actually sublux inferiorly under gravity. So these static structures provide constant non-contractile support, like fixed guy wires on a tent.
Okay, the fixed infrastructure.
Right. Dynamic stabilizers, on the other hand, are the active muscular components. They are the responsive, adaptable elements. They generate force to compress and precisely position the humeral head against the glenoid during movement. These primarily involve the rotator cuff muscles, the long head of the biceps tendon, the intriguing rotator interval we mentioned, and the broader group of parascapular muscles. Their collective coordinated action maintains joint alignment and allows for efficient, controlled movement throughout that vast range of motion. They are constantly adjusting to the demands of movement, providing stability exactly when and where it's needed most. It's this intricate, almost balletic dance between passive anatomical restraints and active muscular control that allows the shoulder to be both incredibly mobile and yet surprisingly stable, though clearly prone to injury when this delicate balance is disrupted.
A balletic dance. I like that analogy. Let's delve deeper into these dynamic stabilizers then. Starting with the rotator cuff. It's often talked about almost like a single unit, but it's a group of 4 distinct muscles. Could you detail their individual contributions and how they collectively function as dynamic stabilizers? You mentioned force couples earlier.
Absolutely. The rotator cuff is indeed a collective term for 4 distinct muscles: the supraspinatus, infraspinatus, subscapularis, and teres minor. Their primary biomechanical function, which is often misunderstood as simply rotating the arm, is actually to stabilize the glenohumeral joint. They do this by compressing the humeral head against the glenoid. They essentially act as the joint's dynamic stabilizers, creating that balanced force couple that keeps the humeral head perfectly centered in the shallow glenoid fossa as the arm moves. Think of them like a coordinated quartet.
Okay, compressing the ball into the socket.
Precisely. Let's look at their individual roles, which are quite distinct. The supraspinatus originates from the supraspinous fossa and inserts on the superior facet of the greater tuberosity. It's unique because it primarily initiates the first 0 to 15 degrees of shoulder abduction, lifting the arm away from the body. Beyond that, studies also show it plays a crucial role in resisting inferior gravitational translation of the humeral head. It's innervated by the suprascapular nerve.
So it starts the lift and stops the drop.
In simple terms, yes. Then the infraspinatus, originating from the infraspinous fossa and inserting on the middle facet of the greater tuberosity, alongside the teres minor, which originates from the dorsal scapula and inserts near the infraspinatus. These 2 muscles are the key external rotators of the humerus. They also contribute significantly to joint compression and counteract anterior and superior humeral head translation, especially important during overhead movements. The infraspinatus is most effective at lower abduction angles, while the teres minor provides consistent external rotation force over a wider range. Both are absolutely crucial for clearing the greater tuberosity from under the acromion during overhead motion, thereby decreasing subacromial impingement risk. The infraspinatus is also innervated by the suprascapular nerve, while the teres minor gets its supply from the axillary nerve.
Okay, the external rotators clearing space.
Correct. Then the subscapularis. It's the largest and strongest rotator cuff muscle. Originating from the subscapular, it inserts at the lesser tuberosity and into the anterior capsule. It functions primarily in internal rotation and abduction, critically stabilizing the joint anteriorly. Peak internal rotation torque is generated at 0 degrees abduction. It's innervated by the upper and lower subscapular nerves.
The big internal rotator and anterior stabilizer?
Exactly. And these muscles don't work in isolation. They create those balance force couples. For example, the subscapularis anteriorly and the infraspinatus minor posteriorly work antagonistically to compress the humeral head, preventing excessive anterior-posterior translation. A compelling cadaveric study showed that paralyzing just these muscles led to significant superior glenohumeral instability. It really highlights their coordinated role.
So they pull together to keep things centered.
Precisely. The long head of the biceps tendon, LHBT, also contributes to dynamic stability, particularly when the rotator cuff is dysfunctional. It acts as a humeral head depressor, limiting anterior translation and torsional forces and reducing stress on the inferior glenohumeral ligament. It essentially helps to center the humeral head, acting as a sort of fulcrum for arm elevation. Its stability is critically enhanced by the SGHL and subscapularis.
So the biceps isn't just for flexing the elbow.
Not at all. It has a key role in shoulder stability, too. And beyond the immediate cuff, the broader parascapular muscles are crucial. Muscles like the pectoralis minor, serratus anterior, rhomboids, latissimus dorsi, and trapezius. They serve to anchor the scapula, allowing it to function as a stable base for the glenohumeral joint.
The shoulder blade needs to be stable, too.
Absolutely essential. For instance, the serratus anterior and trapezius enable scapular rotation, which is essential for abduction beyond 90 degrees. They help prevent impingement by facilitating scapular upward rotation, posterior tilt, and external rotation, a truly coordinated movement. Clinically, paralysis of the trapezius, for example, significantly decreases overall shoulder girdle stability. It's this combined, intricate activation of all these muscle groups that allows for controlled, wide-ranging shoulder motion without instability.
That's an incredibly clear breakdown of the active muscle groups and how they work in concert. You also mentioned the rotator cable and rotator interval as crucial but perhaps more recently appreciated stabilizers. What exactly are these structures and why have they garnered such significant interest, especially regarding degenerative conditions?
Yes, these are fascinating areas that have truly evolved our understanding, especially in degenerative conditions and tiers that aren't immediately obvious. The rotator cable and rotator interval are increasingly recognized for their vital role, even though they aren't visible on plain X-rays. We really rely on MRI for their assessment.
Okay, so what is the rotator cable?
The rotator cable originates from the coracohumeral ligament and elegantly divides into superficial and deep layers. This structure encircles the rotator cuff and inserts onto both humeral tuberosities. Its deeper layer forms a crescent shape, extending posteriorly from the anterior supraspinatus insertion to the inferior infraspinatus border. This arrangement significantly contributes to superior rotator cuff stability, acting as a critical load-bearing structure. Research indicates rotator cable thickness varies, and interestingly, older shoulders tend to have thicker cables.
Thicker with age. Why would that be?
It suggests an increased reliance on this structure for stability with age, perhaps as a compensatory mechanism for other degenerative changes in the cuff tendons themselves, like the body reinforcing a critical suspension bridge as it ages.
Interesting analogy. And the rotator interval.
The rotator interval is a triangular space. The anterior portion holds the most clinical relevance. It's bordered superiorly by the supraspinatus tendon, inferiorly by subscapularis, laterally by the coracohumeral ligament, and medially by the SGHL. This interval houses several key structures: the LHBT, the coracohumeral ligament, and the SGHL. Functionally, it acts as a crucial soft tissue restraint, securing the LHBT in its groove and preventing anteromedial subluxation during external rotation and anteroinferior subluxation during abduction. It also restricts excessive inferior movement. Anatomical variations here can contribute to pathology.
Such as?
Well, for instance, a contracture of the rotator interval is a characteristic feature of adhesive capsulitis, or frozen shoulder, leading to restricted motion. Conversely, laxity of the rotator interval can result in a visible sulcus sign that dimple below the acromion, indicating inferior laxity when the arm is pulled down. These structures, while maybe not immediately obvious, are vital for the subtle dynamic control of the humeral head.
Absolutely fascinating how specific these structures are. It's clear that stability isn't static, but incredibly position dependent. Could you walk us through how different arm positions engage different stabilizers? Why is understanding this so important for clinical assessment and rehabilitation?
Indeed, the glenohumeral joint employs a highly dynamic strategy where specific structures are meticulously recruited based on arm position. Understanding this position-dependent recruitment is absolutely crucial for clinical diagnosis, for identifying the mechanism of injury, and for guiding effective rehabilitation. It helps us pinpoint which structures are under stress and thus potentially injured in specific movements or trauma. It's a prime example of the body's adaptive capacity.
Okay, so let's take some common positions. What about when the arm is just hanging by the side?
Right. At 0 degrees of abduction, adducted, neutral rotation, the subscapularis muscle, provides substantial anterior stabilization. In this position, the superior glenohumeral ligament, SGHL, along with the coracohumeral ligament, CHL, are the primary static restraints to inferior and anterior translation. They bear the brunt of the load, keeping the humeral head in place against gravity. Think of someone standing relaxed. These ligaments are quietly working.
Okay, what happens as we lift the arm slightly, say to 45 degrees?
Moving to 45 degrees of abduction, especially with external rotation, the middle glenohumeral ligament, MGHL, becomes particularly significant. In this mid-range, the MGHL, along with the anterior fibers of the inferior glenohumeral ligament, IGHL, shares the stabilization role and experiences the greatest strain. The MGHL specifically resists both anterior and posterior translation in this position. This is a common position for reaching forward or slightly to the side.
Right, and then the most vulnerable position, that 90 degrees abduction with external rotation.
Exactly. When the arm reaches 90 degrees of abduction with maximum external rotation, the classic throwing position, the late cocking phase, or bracing for a fall, the inferior glenohumeral ligament, IGHL, becomes a primary static stabilizer, particularly its anterior band. This position, as you can imagine, profoundly predisposes the joint to anterior instability. If we see a traumatic anterior dislocation, the Bankart lesion detachment of the anteroinferior labrum often involves the IGHL's anchor because it's the weak link under immense tensile stress here. Conversely, the posterior band of the IGHL is the most important restraint to posterior subluxation when the arm is at 90 degrees of flexion and internal rotation. Its tightness in this position can actually lead to internal impingement, common in throwers.
So different parts of the IGHL complex are crucial depending on rotation at 90 degrees.
Precisely. So you can clearly see the shoulder isn't passively stable across all ranges. Instead, it meticulously recruits specific ligaments and muscles to provide reinforcement exactly where and when it's needed most, constantly adapting to the dynamic demands of movement. This adaptive stability is a marvel, but also explains why certain positions are inherently more vulnerable. As clinicians, being able to identify these vulnerable positions and the structures at risk is paramount.
The shoulder's mobility is legendary, allowing for such incredible ranges of motion. But how exactly does it achieve this vast range, and what are the specific muscles responsible for these precise movements? Let's now dive into the biomechanics of glenohumeral joint motion.
The glenohumeral joint truly permits a vast range of motion across multiple planes, often allowing up to 180 degrees of abduction and flexion. But this total motion isn't solely from the glenohumeral joint itself. It's a highly coordinated effort, a true symphony of movement. Approximately 120 degrees occurs at the glenohumeral joint, and another 60 degrees comes from the scapulothoracic articulation, the shoulder blade moving on the chest wall.
Ah, that classic 2.1 ratio of glenohumeral to scapulothoracic motion.
Exactly. That rhythm is absolutely crucial for achieving full upper limb elevation, preventing impingement, and distributing stress. If it's disrupted, it immediately signals pathology. When we speak of motion, we consider several key planes. Flexion moves the upper limb anteriorly in the sagittal plane up to 180 degrees. Key muscles are the anterior deltoid, coracobrachialis, and pectoralis major, with a bit of help from the biceps brachia. Extension moves the limb posteriorly, about 45 to 60 degrees. Principal extensors are the posterior deltoid, latissimus dorsi, and teres major. Internal rotation, turning the limb towards the midline, achieves 70 to 90 degrees. The subscapularis, pec major, latissimus dorsi, teres major, and anterior deltoid are the main players. Subscapularis is dominant here. External rotation, turning the limb away from the midline, normally reaches 90 degrees. The infraspinatus and teres minor are chiefly responsible. Adduction, moving towards the midline in the coronal plane, is mainly driven by the latissimus dorsi, teres major, and pectoralis major. And adduction, moving away from the midline in the coronal plane, reaches about 150 degrees.
And that's phased, isn't it?
Yes, very much so. Supraspinatus initiates the first 0 to 15 degrees. Then the middle fibers of the deltoid take over, becoming the prime abductor from 15 to 90 degrees. Beyond 90 degrees, scapular rotation, facilitated by the trapezius and serratus anterior, is absolutely essential to achieve full elevation and prevent impingement. And there's a crucial biomechanical detail here. Abduction in the pure coronal plane often requires obligate external rotation of the humerus to prevent the greater tuberosity hitting the acromion.
Right, you have to rotate outwards to clear the bone.
Precisely. This need for external rotation isn't as prominent when movement occurs in the scapular plane that's about 30 to 45 degrees anterior to the coronal plane. This plane is often more functional and allows more effective deltoid function, often being the plane of choice for rehab exercises. What's truly fascinating here is the concept of muscle redundancy. Yes, the shoulder is actuated by large surface muscles and deeper rotator cuff muscles. This means multiple muscle force combinations can produce the same joint torque and acceleration. It's an over-engineered system in the best possible way, providing incredible adaptability and robustness, though it's a challenge for researchers trying to model exactly which muscles fire when needing complex tools to simulate it. This intricate coordination and redundancy enable such fluid and powerful movements.
It's clear how many muscles are involved, each with a very specific role. It really is a symphony, as you said. Now, how do the nervous and vascular systems support this incredibly active joint? Are there particular structures or pathways that clinicians need to be especially mindful of, perhaps those that are particularly vulnerable during injury or surgery?
Understanding the neurovascular supply is paramount, yes, particularly due to the vulnerability of certain structures. Clinicians must be acutely aware of these pathways. Damage can have profound consequences. The glenohumeral joint is primarily supplied by nerves originating from the brachial plexus, that complex network from C5 to T1. Key nerves include the suprascapular, lateral pectoral, and subscapular nerves. But the one clinicians need to be acutely aware of, perhaps above all, is the axillary nerve.
Why is the axillary nerve so critical?
Because of its close proximity to the joint. It originates from the posterior cord, courses along the subscapularis, then travels intimately along the inferior glenohumeral joint capsule. It wraps around the surgical neck of the humerus, often alongside the posterior circumflex humeral artery as it enters the quadrangular space. This anatomical course makes it highly susceptible to damage during shoulder dislocations, or sometimes even during reduction attempts.
So it's right in the firing line during a dislocation.
Exactly. Injury can lead to potential deltoid paralysis, significant weakness in shoulder abduction, and that characteristic loss of sensation over the lateral shoulder, the regimental badge area. It also supplies the teres minor. It's almost living dangerously anatomically speaking. We also have the suprascapular nerve, innervating supraspinatus and infraspinatus. Its vulnerability, especially at the suprascapular notch, can cause rotator cuff weakness, and the subscapular nerve innervates the subscapularis.
Okay, so axillary nerve protection is key. What about blood supply?
For blood supply, the joint primarily receives nourishment from branches of the axillary artery, the posterior circumflex humeral artery, PCHA, and the anterior circumflex humeral artery, ACHA. The PCHA contributes more significantly, about 64%, to the humeral head's blood supply. It perfuses the lateral, superior, and inferior quadrants. This makes it the main blood supply.
So damage to the PCHA is bad news for the humeral head.
Very bad news. Potential of vascular necrosis. The ACHA contributes about 34%, mainly to the inferior aspect. Its ascending branch gives rise to the arcuate artery, entering the bicipital groove. The subscapular artery also sends branches. Awareness of these vessels is absolutely vital during surgery, particularly around the bicipital groove or when plating complex proximal humerus fractures, to avoid devastating complications like AV and bone death. Veins accompany these arteries for drainage.
Right, and lymphatics.
Lymphatic drainage of the upper extremity, including the glenohumeral region, largely flows towards the axilla through various groups of axillary nodes: pectoral, subscapular, humeral, central, apical. Efferent vessels form the subclavian lymphatic trunk, draining eventually into the venous system. As many listeners will know, assessing axillary nodes is vital for breast cancer staging. But clinicians must also be mindful that disrupting this drainage, say during axillary lymph node dissection, can lead to lymphedema, that painful, often debilitating swelling of the upper limb.
A crucial consideration in many contexts. Finally, before we move to pathologies, let's consider physiological variations. Are there common variants in glenohumeral anatomy, and how might these subtle differences influence function or clinical presentation?
Indeed, anatomical variability is quite common and can be highly significant. Recognizing these variants is essential for precise, personalized clinical practice. Firstly, glenoid cavity variations. The glenoid, the socket, may be pear-shaped, most common, oval or inverted comma-shaped, least prevalent.
Does the shape affect stability?
It does. The oval shape generally offers the greatest inherent stability due to its geometry, while the inverted comma shape is considered the least stable. These variations directly influence prosthetic design in shoulder arthroplasty. The surgeon must choose a prosthesis that optimally matches the patient's native anatomy. Furthermore, these subtle differences can affect movement mechanics, particularly in overhead athletes, where slight incongruities might lead to issues over time. Anatomical studies show the glenoid often has an average upward tilt of 5 degrees and about 5 degrees of retroversion relative to the scapular body axis, though these measures are highly variable.
So no two shoulders are truly identical.
Pretty much, yes. Secondly, humeral head shape variations also exist and are clinically relevant, particularly regarding the LHBT reflection pulley. The head shape may be flat, convex, spiculated, or mixed. Interestingly, flat heads are more common in men and younger individuals, while convex ones are more prevalent in women and older individuals. These variations highlight the need for a comprehensive understanding of individual patient anatomy when considering treatment, especially for biceps issues or prosthetic selection. Recognizing these variants allows for a more personalized approach, moving beyond a one-size-fits-all model.
Given its complex anatomy and extreme mobility, it's perhaps unsurprising that the glenohumeral joint is indeed prone to injury. Let's shift our focus now to the common pathologies. Where do you usually see the most frequent issues arising, and what are the key clinical implications for our patients?
The inherent instability we've discussed makes it susceptible to a wide range of injuries. Understanding these is absolutely central to orthopedic practice. From a prevalence standpoint, shoulder dislocations are by far the most frequent joint dislocation in the entire body.
Most frequent in the whole body.
Yes, accounting for up to 45% of all dislocations, a remarkable statistic. Anterior dislocation is the overwhelming majority, comprising about 96% of cases. It typically results from a forceful mechanism, often with the arm abducted and externally rotated to fall on an outstretched arm, a sports tackle. These events often cause specific associated bony lesions, which are important to look for. We frequently encounter Hill-Sachs lesions, impaction fractures of the posterolateral humeral head against the glenoid rim, and equally common, Bankart lesions, detachment of the anteroinferior labrum, sometimes with a glenoid rim fracture. It's the IGHL anchor pulling off.
The structures we discussed being stressed in that position.
Exactly. Posterior dislocation, in contrast, is far less common, only 2% to 4% of cases. These often arise from indirect mechanisms like powerful muscle contractions from electric shock or convulsions. The strong internal rotators overpower the external ones. The incidence is around 17 per 100,000 annually, with peaks in young men, 21-30, often sports, and older women, 61 to 80, likely falls. Immediate treatment is analgesia and skilled close reduction. A significant clinical concern is the high recurrence rate, averaging around 50%.
50% recurrence, that's huge.
It is, and the risk is even higher for those who dislocate younger. This prompts that important question. Should younger patients have early surgical stabilization? And as we discussed, the axillary nerve is particularly vulnerable during dislocation or reduction. Careful neurovascular assessment afterwards is paramount.
Beyond those acute traumatic events, chronic conditions like frozen shoulder or adhesive capsulitis and rotator cuff injuries are incredibly prevalent. They often cause long-term pain and disability. Could you elaborate?
Absolutely. These are extremely common presentations in both primary care and specialist clinics, often causing significant pain and functional limitation, and they can be quite frustrating for everyone involved. Adhesive capsulitis or frozen shoulder is a debilitating condition. It's characterized by inflammation and progressive stiffness of the glenohumeral joint capsule. This leads to significant restriction in both active and passive motion and chronic pain, often worse at night. It affects about 3% of the general population, more common in women aged 40-70. What's particularly interesting, and a diagnostic clue, is its strong association with certain systemic conditions. Key risk factors include diabetes mellitus, especially poorly controlled connective tissue diseases, thyroid disease, heart disease. Even some antiretroviral therapies have been implicated. It suggests a systemic inflammatory component. Management often starts conservatively. Physical therapy to regain motion, analgesics, intra-articular steroid injections to reduce inflammation. In persistent cases, manipulation under anesthesia or arthroscopic capsular release might be needed. Encouragingly, despite its often protracted course, sometimes years, most individuals eventually regain about 90% of their motion. But it demands patience.
Patience and persistence with rehab. And rotator cuff injuries. You said they're the main cause of shoulder pain in primary care.
Arguably, yes. Given the cuff's crucial role in dynamic stability, its tendons are frequently injured. This umbrella term covers a spectrum: subacromial bursitis, tendinitis, impingement syndrome, and various types of tears. Patients with impingement or bursitis typically report pain, during overhead activities, often in that characteristic painful arc between 60 and 120 degrees abduction. Most cases initially improve with structured physical therapy, focusing on strengthening and mechanics. Persistent symptoms warrant specialist evaluation.
And the tears themselves.
Rotator cuff tears can be chronic, from degeneration and microtrauma, or acute from trauma. They can be partial or full thickness. Traumatic tears are less common in younger athletes. Overuse injuries, often linked to degeneration or impingement, increase with age, especially with repetitive overhead activities. Patients typically experience persistent pain, often worse at night, making sleep difficult, and significant difficulty lifting or rotating the arm. It really impacts daily function and quality of life.
And finally, before we move to treatment, what about osteoarthritis of the glenohumeral joint? How does that typically manifest, and what are the initial management approaches?
Shoulder osteoarthritis, or glenohumeral arthritis, is common and increasingly debilitating. The joint space narrows due to capsule thickening and progressive degeneration of articular cartilage and underlying bone. While it can start as early as age 50 from wear and tear, its prevalence and severity increase significantly with age. Clinically, patients present with chronic, deep-seated shoulder pain, progressive stiffness, and gradual loss of motion, often accompanied by crepitous grinding sensations during movement.
And the first steps in management.
Typically conservative, aiming to alleviate symptoms and improve function without surgery. This includes oral analgesics, intra-articular injections like corticosteroids or sometimes hyaluronic acid, though evidence varies for the latter. And dedicated physical therapy programs are key, maintaining motion, strengthening surrounding muscles, patient education on activity modification. Acupuncture is sometimes used, but evidence is a bit inconclusive. The goal is to alleviate symptoms, improve function, and delay surgery for as long as possible. However, if pain persists despite maximal non-operative efforts, function worsens, or quality of life is severely impacted, that often signals a clear need to consider surgical intervention.
That brings us neatly to the surgical considerations and the rehabilitation journey. When conservative measures for conditions like osteoarthritis or the aftermath of complex fractures just aren't working anymore, what are the modern surgical options, particularly in shoulder arthroplasty?
For severe joint degeneration or complex fracture sequelae, yes, joint replacement surgery, or arthroplasty, has become a primary and highly effective treatment. It involves surgically removing the damaged bone and cartilage and meticulously replacing them with prosthetic materials. The aim is to restore anatomy, restore function, and most importantly, alleviate that chronic pain.
What are the main types of shoulder replacement?
There are several key options chosen based on the specific patient pathology. Hemiarthroplasty, where only the humeral head is replaced with metal, leaving the native glenoid. Often chosen if the glenoid cartilage is okay or in certain fracture situations. Total shoulder arthroplasty, TSA, replacing both the humeral head, metal, and the glenoid cavity, usually polyethylene. Considered the gold standard for many cases of primary OA where both sides are worn out. And increasingly, reverse total shoulder arthroplasty, RTSA.
The reverse. That seems to have really taken off.
It really has. It's gained significant popularity and broader indications, almost revolutionizing care for a specific group. It's becoming the treatment of choice not just for older patients, but sometimes younger ones too, and particularly for complex conditions like rotator cuff arthropathy, that's arthritis, with a massive irreparable cuff tear, or for severe fracture sequelae with cuff deficiency. Its unique design compensates for a non-functional rotator cuff, a real game changer for many.
This reverse total shoulder, it truly has revolutionized care for so many, especially those with rotator cuff deficiency. From a biomechanical standpoint, how does it actually trick the shoulder into functioning when the primary movers, the rotator cuff, are no longer there, and what challenges still persist?
That's an excellent way to put it. It really does trick the shoulder, or perhaps re-engineers it as a better term. The reverse total shoulder arthroplasty, particularly based on the Grammett concept from the 1980s, is indeed transformative. It was specifically designed for those challenging situations with a deficient or irreparable cuff, leading to a painful, often pseudo-paralyzed shoulder where the patient just can't actively lift their arm effectively. In such cases, a traditional TSA would be largely ineffective because it relies on a functional cuff.
So what's different about the reverse design?
The core innovations are quite radical, fundamentally altering the biomechanics. One, it features a large glenoid hemisphere, or glenosphere, which is convex, replacing the native concave glenoid. Crucially, this has no neck and is fixed to the scapula. This medializes and stabilizes the center of rotation. It moves the fulcrum. 2. The humeral component is a small humeral cup, concave, almost horizontally oriented with a non-anatomic inclination of 155 degrees. It covers less than half the glanosphere.
So it literally reverses the ball and socket.
Exactly. This design dramatically alters the biomechanical environment. By medializing the center of rotation, it achieves several critical outcomes. Firstly, it minimizes torque on the glenoid component, significantly protecting against early loosening, a major historical failure point. Secondly, and most importantly, it leverages the deltoid muscle far more effectively. By shifting the fulcrum medially and inferiorly, it puts the deltoid on a much more advantageous line of action. It recruits more anterior and posterior deltoid fibers to act as primary abductors, essentially compensating for the deficient cuff. The deltoid becomes the main elevator. Thirdly, it lowers the humerus relative to the acromion, restoring and often increasing deltoid tension. This further enhances the deltoid's ability to lift the arm.
So it makes the deltoid do the work the rotator cuff can't.
Precisely.
Hey.
Clinically, this means the reverse prosthesis can restore active elevation above 90 degrees in patients with otherwise irreparable cuff-deficient shoulders. It provides a functional range previously unattainable. The clinical experience often lives up to this concept, offering patients a return to independence.
That's remarkable. But you mentioned challenges still exist.
Yes, limitations do persist, and it's important to be aware of these. External rotation often remains limited, particularly if the T's of minor muscle, a key external rotator, is absent or severely fatty infiltrated. It really relies on what external rotation capacity is left. Internal rotation is also rarely fully restored, which can affect certain daily activities like tucking in a shirt or reaching the back. Scapular notching is a common radiological finding, seen in maybe up to 68% of cases in some studies.
What's scapular notching?
It's where the humeral cup impinges on the scapular neck during adduction. This can potentially lead to polyethylene wear and bony lysis of the scapula. While it doesn't always cause symptoms, it's a concern for long-term loosening of the glenoid component and potential need for revision. Also, results can be less predictable, with higher complication and revision rates in revision surgery compared to primary cases. Common complications can include dislocation, often from insufficient deltoid tension or malpositioning, infection, aseptic loosening, paraprosthetic fractures, and even axillary nerve palsy due to its proximity.
Okay, so still potential pitfalls. What about using it for complex fractures?
Regarding fracture sequelae, especially complex proximal humerus fractures, the success of arthroplasty can be unpredictable. A significant factor affecting function is the need for a greater tuberosity osteotomy, cutting off and reattaching the bone fragment where the cuff tendons insert. Studies indicate that if prosthetic replacement can be done without this osteotomy, outcomes are far better. All excellent and good results in one large study were in cases where it wasn't needed. Conversely, if a tuberosity osteotomy is performed, active elevation above 90 degrees is often not regained, leading to fair or poor results. This really underscores the need for modular adaptable prostheses that can accommodate distorted anatomy and minimize the need for these osteotomies.
That's a comprehensive and very insightful overview of the surgical landscape, particularly that grommet concept. Finally, regardless of whether it's a conservative or surgical path, rehabilitation is paramount for the glenohumeral joint. What are the key principles and phases of this crucial journey for our patients?
Rehabilitation is absolutely crucial, yes, for restoring optimal function, strength, and stability after any injury or surgery. It's a structured, progressive journey, ideally supervised by a dedicated healthcare professional, like a physical therapist, to ensure safety and effectiveness. For many patients, it's definitely a marathon, not a sprint.
What's the main goal?
The primary goal is to facilitate a safe return to daily activities and prevent re-injury. That's vital for everyone, athletes and the general population alike. Strengthening the muscles around the shoulder, the rotator cuff and parascapular muscles is essential for improving dynamic stability, reducing pain, and supporting the joint's integrity. Consistency in applying the exercises and adhering to the program is truly the cornerstone of success. Patient commitment often dictates the outcome.
Okay, so how does it typically start? The initial phase.
It typically starts with an initial phase, often called the protection or acute phase. This focuses on gentle range of motion exercises once the acute injury or immediate post-op phase has subsided and pain is manageable. The emphasis here is on promoting flexibility, preventing stiffness, and gradually restoring passive movement without stressing healing tissues. Key exercises in this phase often include pendulum swings, leaning forward, letting the affected arm hang freely, and gently swinging it in small circles or back and forth. It targets the deltoids and cuff in a non-weight-bearing, gravity-assisted way. Simple but effective. Crossover arm stretch. Gently pulling one arm across the chest with the opposite hand, keeping shoulders relaxed. Targets the posterior deltoid and capsule, helping restore flexibility, especially for internal rotation.
Gentle movements to start.
Very gentle, yes. Often performed in sets, maybe 5 to 6 days a week. The focus is on gradual improvement, always listening to the body to avoid exacerbating pain. It's a delicate balance. As recovery progresses, and crucially under guidance, patients move to an advanced strengthening phase. This introduces exercises to build functional strength, endurance, and stability, preparing the shoulder for more demanding activities.
What kind of exercises are typical here?
Examples include push-ups, progressing from wall push-ups to knee push-ups, then full push-ups. Strengthens chest, shoulders, triceps, and engages the whole shoulder girdle for stability. Overhead dumbbell press. When done correctly, enhances shoulder stability and strength, engages deltoids, cuff, and core. Form is vital to avoid impingement. Single-arm dumbbell row focuses on strengthening the muscles around the shoulder blades, rhomboids, lats, improving scapular control and stability. Crucial for that 2.1 rhythm.
So building up strength and control.
Exactly. Throughout all phases, consistency remains paramount. Regular sessions, proper warm-ups, cool-downs, and having a supportive environment, family, friends, support groups can significantly enhance motivation and accountability throughout what can be a long and challenging process. It truly is a partnership between the patient and their clinical team to achieve the best possible functional outcome. #outro Taven.
This has been an incredibly insightful deep dive into the glenohumeral joint. From its delicate anatomical balance and the sheer genius of its biomechanics, to the complexities of its pathologies and the nuanced approaches to rehabilitation, you've provided a truly invaluable understanding. The adaptability of the human body, even facing such a mobile yet vulnerable joint, is truly fascinating. What's one final provocative thought you'd like our listeners, who are all deeply engaged in advancing their clinical understanding, to consider about the glenohumeral joint as they continue their practice?
My concluding thought would be this. Given the glenohumeral joint's remarkable capacity for motion, balanced by its inherent instability, it really stands as a prime example of how interconnected structural integrity and dynamic function truly are. As you all continue your practice, always consider not just the single injured part, but the entire kinetic chain. Think about how compensatory mechanisms might be at play, both beneficially and detrimentally, in a patient's presentation. It's a system, you see, not just an isolated joint. And understanding that whole picture is absolutely key to truly excellent patient care.
A profound point indeed, seeing the shoulder not just as a joint, but as a dynamic system within a larger chain. That's a perfect note to end on. Thank you so much for sharing your exceptional expertise with us today, and thank you for joining us on the deep dive. If you found this discussion valuable, please do consider leaving us a rating and sharing this deep dive with colleagues who might also benefit. It truly helps us bring more expert conversations to you. Until next time, keep exploring, keep learning.